Hey, good evening, Eric. Another late podcast,
Another
which
late
is just not
podcast.
not my favorite, but hey, we're here. We're
Yeah,
doing it.
we're live and local. At least it's a Saturday night,
At least it's a Saturday night.
you
Absolutely.
know. Hang out a little bit,
Not going to work at 6 a.m.
talk about our dogs. I love it. I love it. I love it. Yeah, man. It's a perfect, I might say, perfect fall day out there. I don't know what it's like out there in Maine, but it is money here in Minnesota.
Yeah, we're like low 70s, high 60s. Beautiful. It's so freaking nice, dude. It's great.
Yep. Yep. This is what we live for. This is what we live for. That's what I live for, at least.
Yeah, the 2 months of warmth we have.
Christian and I, we were talking earlier this week about a podcast to do. And we decided let's talk about a podcast on what we do when things with patients don't always go the way we want them to go. Because shocker, believe it or not, Christian and I aren't perfect and we don't get everyone better every time. Well, maybe Christian does. I don't. I'll be humble about it.
No, I certainly do not.
You know what? On second thought, I think I do. I think I get everyone better every single time. Doesn't matter. I can
You
promise you
keep
that.
telling yourself that, yeah.
I'm going to be just like all these people online. It works every time. 5 ways to get your back pain better. Bulletproof. Bulletproof your back every time it works. No, that's not the case. That's a bunch of BS. But yeah, so we're just going to go through some stuff when things aren't working out. What do we do? What do we say? How do we try and get out of it? Where to go from there? And so to start off, Christian, could you think of a case recently or one in mind where just describe in general if it didn't go the way you wanted it to go? You're thinking too long about this. See, I told you, you get
Yeah,
everyone better.
dude,
You get
there's
everyone better, I'm telling you.
it's like which day of the week? Every single day there's someone who's not getting better to the degree that either of us really wants. But how about one today? So today I was in private practice at the rock climbing gym working with one of my first clients that I've had there for his shoulder. He just has some rotator cuff tendon pain, some stiffness in the joint, and it feels tight and it nags at him. And we're just trying to address that with a comprehensive plan of some stretching, definitely some strengthening, and then a lot of manual therapy because he really seems to enjoy it. It's been really helpful for him too. And I've been working with him off and on for the last, let's say 2 months. We've probably done 5 sessions or so over that time. He's gotten a ton better, but he still has this nagging tightness in the back of his shoulder. And obviously he wants it gone. He wants things to feel symmetrical. And we had a conversation today about, is that a reasonable thought to have? Are you going to ever feel perfectly symmetrical, not really feel any tightness in an area? And he already knew that wasn't a realistic expectation. He just wanted to talk about the appropriate expectations. And I told him, like, honestly, you're probably going to get looser and looser over time. It's going to slowly happen. And the progress you're going to get is going to be really quickly early on. But then you're going to have that last 15, 10%, whatever it is, that takes many, many more months to clear up. But part of the problem is that your body keeps a memory of how things have been. You've had a sore shoulder like this for 2 to 3 years. It's going to take a very long time for it to feel really good. And so I'm not saying that I had to change our plan a whole lot. It was just, we have this kind of conversation all the time with people where the first day we meet, we set expectations, and it's always an estimate. Sometimes I'm a little off. I'm off by a month, off by a week, sometimes off by a year. I don't know, but just making sure that we touch base on those expectations every so often to ensure that everyone's on the same page.
Yeah, I mean that's like you said, which day? I mean that can be a
Which day?
daily occurrence, you know. Yeah, I mean I think back to my own caseload right now. I got a couple of patients that are just like we just can't seem to find that headway into their pain, right? For me comes very particular. I can think of one case, and she's a farmer. This middle-aged lady with neck pain, and right now it's in the middle of harvest season. You know, she's she's collecting all of her crops and doing a lot of packaging and storing and lifting, and a lot of what she does, she has to look up to do it. And we had to have that conversation. She has like 2 more weeks left, I think, of like harvest season, and we just had to have the conversation this week and say, hey, you know what? Right now we're just trying to keep the boat afloat until this part of your life is over with, and we can modify away from these stressors and stop having to stress that neck daily in ways it doesn't want to be stressed. And so yeah, definitely these types of things come up all the time. And if someone says they don't, they're probably lying to you. Uh, and I think this is where it can make PT in particular be, you know, I guess difficult, but also a like intriguing profession. It's a puzzle that you have to try and figure out. And not every puzzle you either have all the pieces right away or, they all fit perfectly, whatever it is. And it can take a little bit. And so let's kind of dive into some of those things in terms of the puzzle pieces and why things might not be working.
Yeah, I think that sounds great. So I made a list and you added to it about just reasons that things aren't working, meaning the patient isn't getting better to the degree that they want to get better. So these are in no particular order. We'll go down one by one. First one on the list I had was going too hard too fast, meaning that when we get started with physical therapy, we make the decision that we got to get this person training. They need to do whatever it might be, let's say exercise. And we write them an initial home plan, or like it's been several visits and we're scaling that plan up with higher level movements. And then some number of weeks go by. Next thing you know, they're feeling worse. They feel like they're doing too much. We made them go too hard too fast. And now we got to figure out how to put out that fire. It's anytime you get someone started on a plan, I tell every patient, I'm like, this is my best guess. When I meet them, I'm like, these exercises at these sets and reps and this weekly frequency, whatever it is, this is my best guess for you right now. It will not stay this way. This guess is probably wrong. And we're going to just have to change that or refine it over time based on your response.
Yep. Yep. No, yeah, I have definitely ran into that, right? I say this quite a bit, but I don't think there's such a thing as a bad exercise, just poorly prescribed. And sometimes you might be doing the right exercise, but maybe you just give them too much volume. And that volume, what you thought, because they had low irritability, just hit that tissue just right and did a little bit too much. And now things are a little bit more layered up, right? And kind of the flip side of that coin would be not doing enough. Someone comes in and they seem to have pretty high irritability, and you give them some pretty simple things to do, and it's just not really cracking it, right? You gotta, maybe you need to push into a little bit harder, or whatever that might be. So there's the flip side to that as well, which is you're not going hard enough.
Yeah, I think that one, at least for me, happens less often. I try to be really on top of my expectations, like you're going to start here and we're going to keep scaling this up over time in accordance with your goals and your abilities and such. But when like one instance where I do feel like this happens, and this is something to always be thinking about with every client, is when you're trying to do the blended approach of some manual therapy and some exercise, and someone is kind of flared up still. They're not quite very flared up. They're not quite out of the woods yet. And what they probably need is more hard work. You just got to get them doing more active stuff, and just knowing when to make that switch from spending more of your time on calming things down with manual therapy to getting them doing more active based care. That can be a tough line to cross, but at some point you just got to get rid of that manual therapy stuff and focus more on the active approaches, and usually they'll end up getting better the more work they do.
Yeah. Yeah. Moving on to the next two, I think they kind of go hand in hand. But I mean, you could even think of these next two in terms of like someone who doesn't have pain, but we're just, we're trying to accomplish goals with strength and conditioning, fitness goals. And that's going to be inconsistency or not being committed to it. And we run into this as well. It's the buy-in from the patient, right? Does the patient trust what the physical therapist is saying? Because sometimes if the PT, you can say whatever you want, but if you're not convincing or having the patient be bought in and trusting, and then that can be very tough. And the patient might not be very consistent. They might not be committed to the plan of care going forward because they don't trust your best judgment. And that's another spot where I think as physical therapists, we could be better in terms of getting more buy-in and more trust from the patient.
Something you wrote in your notes later on, which I'm just going to steal from you right now because it's a good place to put it, is that we never want the patient to feel like it's their fault. And honestly, I don't think it is. I'm not here to say that the patient is at fault for not being committed or for being inconsistent. Sure, it might be their fault. They could always do better, of course, but that's not really a constructive way to approach the problem. As I've said, I care about being effective, not being right. And so, in order to be effective with someone who has issues with being consistent for whatever reason, I come at it from the perspective of what can I change about my plan to better suit their life? Are these exercises taking too long? Are they happening too many times in a week? Are you just not feeling like they're doing anything, therefore you're less motivated to do them? So any number of reasons like that is how I like to approach a problem first. And usually the patient and I can work together to create a plan that can increase that consistency, can get them some more buy-in. But off of your point, Eric, yeah, like sometimes you gotta get the patient to buy into the plan. You have to let them know, like, if you do these things, your chance of success is going to go way up. You're going to reach your goals if you do X, Y, or Z. It might take some time, but it's going to happen. Not doing these things is going to get you nowhere except probably worse off. And so we got to figure out how to make this work for you. An issue that I have more personally is that I'm not much of a cheerleader. Like, I'm not going to get the person to just like I'm not going to get all bubbly and excited and get them to do a bunch of different stuff. I'm not that kind of PT. And if you can't tell by my voice, my mannerisms, but all my patients know that I care a lot and I'm going to get them a plan that I know would work if they can do it. And if they need someone who's more of a cheerleader, those people are out there. They have go to one of them or go to a different trainer that's going to get you more jazzed up. And if you can find that the right personality match in that way, that will certainly help with commitment.
Yeah. Yeah, absolutely. Absolutely. And I know I'm going to touch on this later on as well in terms of being super bubbly, but um I mean, I would say that I'm with you in that sense of like I I think there's a time and a place to be, excited and, jazzed up about achievements and whatnot. Whenever someone's doing better, you get excited about it, right? But I think how you communicate to adults is a huge thing because that's who we work with mostly, right? We work with adults, and so treating them like an adult, I think, goes a long way. Anyways, so yeah, definitely the buy-in piece I think is a huge thing. And like I said, I think as PTs we could be better at that. And I think that one of the areas that could help fix this, and I know that you and I try and do it as much as we can, Christian, is motivational interviewing, right? Trying to get down to the root of why someone is doing what they're doing or why they're not doing something or whatever that might be. Figuring out their why I think is a huge piece of it. And if you can play on that, and then it's I think 9 times out of 10 you're going to get that buy-in. Sometimes you get people that come in and they're very skeptical about what we do and about PTs and very unsure how it's going to help them. And, I think that's when you run into that 1 out of 10 patient. It's not just motivational interviewing, but I also think it's kind of flexing your knowledge a little bit, right? If someone comes in and they're skeptical and you give them reason to keep being skeptical, as in you're not telling them the research behind it, you're not educating them on how it's going to help. There's plenty of reasons that we might not be educating patients to the fullest. And I think that when we lack oh man, I might make up this word. If I do make it up, let me know. We'll cut it out. But like the fervor, is that the right word? Like I
It's
said it
a
wrong,
word.
didn't I? It
No,
is a
fervor.
word? Okay.
That's a word. That's a word.
Okay. Maybe we cut that out anyways. Sound like an absolute dumbass over here when we don't say it with enough conviction. That's what I was thinking of.
There we go.
That's when we don't get that 1 out of 10 patient to be bought in. And I tell you what, though, one of the cooler things I feel when it comes to PT is when a patient comes in and they don't think it's going to help and they're just super skeptical and you just blow them away with how it's going to help, what are the things that and you get the buy-in and then they end up getting better like that. And then I've had a couple of patients where like after the fact, like they'll admit it when they get better. They're like, I didn't think this was going to work, but it worked. And it's like, yes, that's a home run feeling.
Yeah, those are great feelings. Like you said, not that common. but they certainly happen. I love winning those ones. It's always some grumpy old dude, like almost always. Yeah. All right.
Yeah, yeah. Anyways, so speaking of grumpy old dudes, just kidding, not really. But the other factor as to why things might not be working, and this is something that you wrote down, Christian, so I'll let you speak on this one, but life isn't helping. Those psychosocial stressors that we know so much about that can play such a huge role.
Yeah. One patient I have right now has chronic neck and shoulder pain. It's gotten a lot better, but she works every single day of the week. I think she works 7 days a week. She doesn't own her own business. She works for someone else. She just is a workaholic. It's what she likes to do. It gives her meaning and purpose in life. And she's always working at her computer, pretty much at the same workstation. And she knows that her neck pain is directly linked with the stress with her work and the duration of her work, but she's not going to change that a whole lot. She's like, I want to try to get this better without changing much of that. Is that possible? Probably, but sure as hell isn't helping the matter. So
Yeah.
you're going to have things like that where the job doesn't help. Or the guy I mentioned with the shoulder pain earlier, the rock climber, he is also a bartender and he's got to do a ton of cleaning, a ton of lifting of heavy stuff. He's always using his arm, and then he's also climbing a lot at a very high level. And that stuff isn't going to help. It's going to make this process be muddier, take longer. You're more likely to have flare-ups because your life isn't helping matters. Then, of course, you have the folks who they have really good intentions. They're trying to be consistent. They're trying to be committed, but they have 3 kids and they've got to go to school and daycare and sports and the kid's sick. And they just, by the time they get a chance to work on themselves, they have no energy left. They want to go to bed. And so a week
Mm.
goes by and they've done their PT exercises once or twice, maybe half of them, half-ass the reps. That's not very helpful. And then something that happens here in Maine, I'm sure by you too, is there's a lot of older folks. A lot of the like 30 to 50, 60-year-olds are also doing some kind of family care where they might be taking care of a parent who's elderly. And so they have to spend some more time doing that kind of work, which just adds to the stress, adds to the physical work that they have to do. And that stuff isn't conducive to the ideal healing environment.
Yeah, yeah, absolutely. Um, yeah, I think the big thing is, I mean, a lot of the time it's just, well, it's just time. It's just that, right? There's only so much time in the day. And I think as a PT, there's just any healthcare provider, we have to know that. We have to be on top of that. We have to know that, that patients only have so much time in the day. And at some point, they want to do something that doesn't involve work or worrying about their pain or rehab, right? They want to just relax. And I think that's important too when it goes back to like their home program, that the going too hard, too fast, the first point we made, we could easily give someone a home program with 10 different exercises, right?
A
Basically
lot of
make it a,
PTs do.
yeah, basically make it a whole freaking workout for them at home. So they're doing an hour workout every day, pretty much. We could easily do that, but that's just not a practical approach for some of these patients. And I honestly, I love it when the patient tells me right away, they'll say, like, I want to do home exercises, but only give me 2 or 3, right? They're like, I don't have time to do 10. Perfect. I appreciate you telling me that. Let's find the best 2 or 3 for you to do for this issue. And so, yeah, life is those psychosocial factors might be, in my opinion, the biggest barrier in terms of why people don't get.
And to be clear, people have the time. People have the time to get these things done. It's they don't have the bandwidth. It's that 15 to 30 minutes of time to do the exercises. They would rather spend sitting on the couch on their phone or playing with their child. I don't know, whatever else they want to do that is just less stressful, because exercise is still going to be stressful. They want to do something different to unwind, and I understand that. And so then when you get those people that are like that, they're going to always prioritize or almost always prioritize something else besides the PT exercises. You got to try to find the minimum effective dose where you're like, okay, what are the 2 exercises I can give you that I know you're going to do? Let's just start there. And I try to be clear with them, like, I hope that this is enough for you. I'm trying my best to make sure it's enough, but it might not be. So if you're not getting the progress that we're looking for, we're going to have a real conversation about doing more. But as long as they know that and they're expecting that this might not work because they're doing too little, I'm good because they're an adult. They're making choices.
Right. Yep, exactly. Yeah. So going on from there, kind of working into more of the specific diagnosis or treatment. I would say, across the board in healthcare, we do our best to diagnose people with the right diagnosis to get them better, right? If we get the right diagnosis, we can do the right treatment based on the right research, and people should get better with it, right? Oftentimes I hear people will be like, I think my doctor just doesn't care, and they just pulled some random diagnosis out of thin air. I don't think that's the case. But to all of our defense, the human body is extremely complex, and we don't always get the right diagnosis right away. What we might think is a radicular pain coming from the low back, maybe it's a lateral glute referral or something, right? And we weren't picking up on it right away. From what maybe we thought was a cervical radiculopathy, maybe it's rotator cuff referral pain, and we're not working on the rotator cuffs the right way. There's many things like that can come up where maybe we just missed a diagnosis. And in those cases, it's good to, I mean, we'll talk about this here in a second when we talk about what we tweak, but we got to circle back around to what that might be, right? Did we miss the diagnosis? And if so, we're probably not treating it the right way.
When it comes to diagnosis, there are the diagnostic changes that matter and the ones that don't. In your example of a lumbar disc herniation causing lumbar radiculopathy down your leg or sciatica versus you have a really sore glute muscle causing a similar kind of pain down your leg. Those are two very distinct, different diagnoses that you're going to treat. There's going to be some differences in how you treat them for sure. But then there's the ones like in your shoulder. Do you have shoulder impingement? Do you have rotator cuff tendinopathy? Do you have a small labral tear? Do you have shoulder arthritis? Those are all treated roughly the same. And the diagnostic label doesn't matter a whole lot, but it does when it does. And that's why you got to make sure you're, at least in my view, like always checking your biases. I'm never married to a diagnosis ever. Always confident, never sure. Like I'm going to deliver a confident message. I'm going to tell them my other thoughts about what diagnoses could be at play here, but I'm never positive. Even if I am pretty positive, I'm never like, I try to not be, because that's when mistakes are made. And that's when someone goes through 6 weeks of PT, doesn't get any better. And you're like, what's going on? Right. Because I have the wrong freaking diagnosis here. And it's my fault
Mm-hmm.
because I got the blinders on just doing my job when I should have been more aware and really taking everything in big picture, as well as being very critical for the patient's plan of care.
Mm-hmm. Yeah. Yeah, absolutely. Absolutely. Um, and I think these next couple, we can kind of lump them all together, right? So we're still talking about reasons why things might not work in PT. And the more we talk about all these reasons, it's kind of astonishing that it does flip and work sometimes. There's so many things that we're talking about, why it won't work. And I wonder if people who are listening to this might be scratching their heads being like, does this ever work? It does work. We promise you it does work. But sometimes it doesn't. And so these next couple, I think we can kind of all lump together. And that's being too general, too specific, or like we already said, doing too much, right? So I think it's some patients, kind of like you said with the shoulder, Christian, right? You could have 5 different diagnoses in the shoulder, and roughly they're going to be treated about the same with the same plan of care. In general, we can be pretty broad with how we treat that and not having to worry about getting the exact tissue structure, the exact diagnosis, because they're all going to be treated relatively the same. And then to your point that you just brought up there, Christian, about having the blinders on, right? That to me is sometimes being too specific, right? Sometimes we can just get honed in and sticking with the low back, we might just be like, I know it's that L5 radiculopathy. I know it is. Clinical prediction rules, everything is saying that it is. It has to be. And you get just bogged down in that when you're not able to see the whole big picture, and you're missing something, right? And so yeah, sometimes I think those two, being too general or sometimes too specific, can definitely come around and bite us from behind sometimes, even though in some cases they're very appropriate to to do that. Some diagnoses is very appropriate to be very specific, and others it's very okay to be more general.
Yeah, and you don't always know which way to go right away. It takes some time and getting a sense of how they're responding for you to decide, should I be more specific or more general? And when I mean too general or too specific, I'm also talking about the way you go about treating. So, for example, with low back pain, a specific way to treat would be I'm going to adjust or mobilize or do deep tissue work or dry needle that specific region of your low back in the hopes that we can calm those symptoms down and you feel a lot better. Being too general would be to ignore all of that kind of stuff and just be like, okay, we're going to have you just do some core stability exercise, maybe a little bit of like leg work, whatever. You're training the areas around the site. We're not doing anything particularly local to that site. And sometimes you just got to branch out. Maybe this is why I just always fall into the hybrid or more moderate approach where I'm going to do all those things probably. And we'll just decide how to prioritize based on how your body's responding and how irritable things are, your preferences, etc. Because when you're too specific, you make mistakes. When you're too general, you make mistakes. I've just found if you try to cover all those different bases at once without being spread too thin, that's tough too.
Mm-hmm.
You're more successful. You can't pigeonhole yourself into diagnosis or treatment.
Yeah, yeah, yeah. I would agree with that. I would agree with that. And a lot of times, this whole PT thing and plan of care, it's a dance. It's going back and forth. Sometimes you're going to be more specific on some days or some weeks. Sometimes you're going to back up and you're going to look at the whole forest and you're going to be more broad on things, right? It's not always set in stone one way. And so, moving on, we already touched on this one a couple of times, but sometimes we're just not a good fit, right? As much as I think I'm the most lovable, person in the world, sometimes it can't happen.
Yeah, they just hate your face,
That's
especially with that stash, dude. If that's what you
that's a
call that.
sarcastic joke, by the way, everybody. You don't like the stash? I think this is
No, I do. It's good.
get closer to
Yeah.
the camera.
Yeah.
Pat it down a little bit. Yeah.
It's do
That's
too.
not creepy at all. It's not creepy at all, right? Probably just lost any chance of getting any type of sponsorship, but that's okay. No, I tell patients almost every day. I say, I think I might have got this from you, Christian. I don't know who, we talk about this all the time. But if I'm not worth your time and if I'm not worth your money or one of those two things, I want you to tell me. And I'm going to try and find someone who does fit those two things, your time and your money, because they're both very valuable to the patient. One of the things that just irks the crap out of me is when people charge patients or clients crazy statements, crazy amounts of money to do things, and they don't get better. And it's been 12 weeks, and they keep charging them. They keep doing the same thing. Come back in, keep doing this. And it's like at some point, I tell a patient, it's like, do you think it's worth your time? Or do you think it's worth your money? If it's not fitting those two, if you're not checking off those boxes with it, I would find something else, including the therapies or the services that I provide. So not a good fit. Sometimes it's just a personality thing. Sometimes it's how you treat, whatever it is. But that's a big one where you got to kind of swallow your pride and find the patient or the client, the right person to get them better. Because that's what matters at the end of the day.
That's all we're trying to do. And yeah, the older I get, the better I get with that. Where being younger, I know I had some ego attached to that where I was like, I need to do this. Like, I know I can, whatever. And now it's like, I've proven to myself that I can get lots of people better. And I've also recognized that I fail every single day. And I would much rather the person that's not thriving with me thrive with someone else sooner than later for what reasons you said, to make sure that they aren't wasting money. They are getting a good experience with someone that they really care about or like working with. And that's just the ultimate goal, is to get them better. And if that means that I'm not the best person for them, fine, I will help you find someone better. And I certainly do that. It doesn't happen that often, but I've done it many times.
Mm-hmm. Mm-hmm. Yeah. Yeah.
I think most of the time, honestly, people aren't going to tell you, and that's fine too. Like, no one's going to tell you like, hey, actually you suck. I'm done. They just don't schedule. They fall off your schedule. Yeah. And I'm like, yeah, all right. That makes sense. Probably what's going on.
Yeah.
That's okay. But usually what I really try to do, which we'll talk about more in the tweaks, is you set the stage of their treatment options. You let them know, like, this is plan A, B, C, D. This is how this stuff will flow. That way they know what their treatment options are, what your different paths to help them are, contingency plans, etc. And if you do that, they don't feel like, oh, I'm just doing PT. If this doesn't work, I'm screwed. It's like, no, no, no. If this
Yeah.
doesn't work for you, we're going to go one of these other routes that have already laid out for you.
Yep. Yep. Absolutely. Okay. Moving on. We're almost done. We're almost done with the pessimistic reasons as to why PT sucks. Let's chop that up and use that as a social media bite. All right. So one of the big ones that I try to address right away in the eval, and I'm sure you do too, Christian, is beliefs around pain. Everyone has different beliefs around pain. It can be individual, it can be cultural, it can be past experience, what they heard on the internet and family and friends. Pain beliefs can vary widely. And I think it's really important that we set appropriate expectations and beliefs around pain to what we know to be true, right? Especially when it comes to like low back pain, neck pain, even like, for example, like knee pain, right? If we think someone might have like a degenerative or age-related tear of their meniscus, it's like, let's set the stage here, make appropriate pain belief expectations so that they know what's going on and what the pain means. Because I think sometimes not having those appropriate beliefs, that can really be a barrier or hindrance.
Yeah. How are you supposed to buy into a treatment plan if you don't understand why you hurt in the first place
Mm-hmm.
or understand what pain is to begin with? And so I try to incorporate that kind of education into every single session that I have with clients. I wouldn't say that I like sit down and give them a pain talk. I used to do that, but now I just blend it into every single thing that I say and that I
Yeah.
do or don't say and don't do. It's all deliberate to help manipulate and control that person's pain processing into a more favorable path.
Yep. Yeah, absolutely. And then lastly is just flat out, some diagnoses are hard to treat. Some are just tough. Like
Plantar fasciitis. Can't
yeah,
stand it.
yeah.
Awful.
Another one that I thought of is a sports hernia, which by the way, what a terrible name.
Terrible name.
It's not always sports related and it's not really a hernia, but neither here nor there. it's, it's a
It's
hard one
probably
to
the worst
treat.
name we have in PT.
Yeah. And so like some things are just hard to treat. Like if I have an 85-year-old, and this has happened, if I have an 85-year-old come in with like a massive rotator cuff repair, yeah, we're probably not going to see full resolution or function of that. Like that's going to be a tough one. It's just some things are tough. And you know, I think it's important to not put I don't think you should tell the patient when you diagnose them with, let's say, like plantar fasciitis and be like, at the end of the visit, son of a bitch, I got to let you know, patient, I hate this diagnosis. This is a tough one. This might not get better. Like, you don't want to say that, but I think it's worth telling the patient, hey, this might take some time, set the stage appropriately. But yeah, some things are just difficult to get better.
That's so true. And just, we have very clear research on this, that a lot of different diagnoses take a super long time. And so you or we might feel like things aren't working, but they actually are, just not at the time scale that you really want it to be. They're going to be working on the order of months, very incrementally, with ups and downs, not in the order of days to weeks. And some of
Mm-hmm.
these things like plantar fasciitis or frozen shoulder, we're looking at 1 to 2 years often for people to feel like, oh, I'm 90% plus better. And that's just
Mm-hmm.
the way it is. And it's
Yep.
our job to tell you that and be like, look, I know some people that you've read about or a friend did this one thing and their plantar fasciitis was gone in 3 months. I hope that happens for you. I'm gonna do everything I can to make that your reality, but let's not have that as our expectation because it's probably not going to happen. And I have that, especially that conversation around injection therapy. Every single patient that I refer for an injection, and I'm talking to them about that because they're always like, oh man, I think if I just got an injection, the pain is going to be gone. I'm like, yeah, maybe 1 in 20 times that might happen. That's a made up number. Most of the time, you're going to get some benefit for some amount of time. No one wants to hear that.
It's the same thing with surgeries. Yep. But but we love our orthopedic surgeons, so I'll never say anything bad about it. All right. Now that we're done with that, how do we tweak? How do we tweak it? Where do we go from here? What do we do as physical therapists to get things better? Right? And so I really like what you brought up first, Christian, on here, which is the dosage, changing the dosage. There's so much to change when it comes to dosage. What we mean by dosage is how much of the exercises you're doing, right? You said that you can do more, can do less, can do the same, can do different. And obviously that's pretty plain in terms of the language there, but it's true though. You could dial things up, dial things back, do something else, or just stick the course. I think that's probably the first spot, at least as a PT, where I start when it comes to why is someone not, when they're not getting better, looking at what are you doing at home, how do we need to tweak this thing, and where can we go?
The dose is incredibly important. Sometimes it's as easy as this person has to do more. So just they went from every other day to every day. Fine. Or you added an extra exercise or a few more reps or one extra set. Cool. That can work. Or you just do the exact opposite. You do less. And sometimes, like I said earlier, you just got to do the same thing. It's your gluteal tendinopathy. That diagnosis takes forever. I'm sorry. This sucks. But I think if you kept doing this, you're going to keep getting better. It's just going to happen very slowly. And I feel comfortable saying this because you're checking a lot of boxes. The exercises feel like they're targeting the area. They feel like they're making you sore, meaning that you're getting some kind of a stimulus for adaptation there. Your body's tolerating them well, meaning you're not getting flared up from doing them, etc. If I'm checking those boxes, I'm comfortable with the exercise plan as it is. If you told me that you didn't feel it or it made you feel a lot worse, things like that, I'm like, all right, maybe this isn't the best choice. And then I'd do something different, which is the last one. Not just different exercises, but a different scheme. Sometimes you got to go for gluteal tendinopathy, maybe I had you doing side lying hip abductions for 3 sets of 10 to 15. Okay, maybe that's flaring it up. How about we just go to side lying abduction isometric holds for 10 to 20 seconds and do multiple rounds of that? Just doing a different set, rep, tempo, whatever type scheme can be all it takes to make the exercise more productive and more meaningful for the patient.
Mm-hmm. Yeah, absolutely. Yeah, it kind of plays into the next one, which is the variety, right? If there's a little bit of the whole like no pain, no gain, like a little bit, you could argue in terms of like pushing into those painful spots, right? Some diagnoses are more appropriate than others. Some we don't want to do that at all. And so, I think like going to your point, like the gluteal tendinopathy, right? Like when it is a tendon issue, we need to be targeting that tendon, right? It needs to be specific to that one spot. You can do some regional interdependence, which is just a fancy word for, or a fancy term of saying like, we're going to work up the chain, we're going to work down the chain because they're going to influence one another and it's going to make it better. Sure. You could be a little more broad with that. But like if someone comes in and they have, like tennis elbow or some type of like Achilles tendinopathy or something like that, like you better be working that common extensor origin, right? You better be working that Achilles. You can't just be like, oh, you have Achilles tendinopathy? We're going to work on your low back posture. That's going to fix it. No, it's not. We know that one needs to be super specific. But if you have someone,
you do, but yeah.
right. If you come in and you have, let's say, like just like general thoracic spine pain, yeah, we might just work first on just getting the whole body moving a little bit more and just see where that takes us. Get the arms moving, do some stuff with the neck, do some stuff with the hips and the low back, and we're gonna go from there, right? So some things can be very specific towards that painful region. Some things are gonna be, maybe a little bit more broad.
Yeah. And when it comes to variety, also considering more variety in exercises compared to what the client does that pisses the area off in the first place. So if I have a runner who hurts in the side of their hip with every impact, I'm probably not going to choose a Peterson squat right away because it's going to load the hip in the exact same irritable way. Less impact, but the tension's roughly the same in the same kinds of muscles. And that's where I might choose a different style of exercising the painful region, like a bridge or a clamshell or a side leg lift, something that's going to challenge the painful area, but in a different way than how it's hurting in the first place.
Yeah. How dare you say clam?
That stuff just
PT
kills me. It's like if
PT
someone has
jokes.
pain in the
Love it.
bicep saying, oh, I'm only going to do rows and pull downs because they're functional. I'm not going to do a bicep curl. Get out of here.
Have you ever tried to lift a dog with one arm? That's all that is. Just a bicep curl. That's just isometric. That's all you're doing. I say dogs because I don't have any kids. So, And that's probably speaking to my lack of experience with kids, because maybe you don't truck them around like an isometric bicep curl. But anyways. All right, Christian, this next one I think is in your wheelhouse a little bit more than mine. But manual therapy, kind of the same thing with exercise, right? Do less, do more, intensity, techniques, etc.
Yeah, I'll speak to that with that same shoulder client this morning. So when it comes to shoulder exercises, or sorry, shoulder manual therapy for him, I started off with a good amount of needling and some massage, which had a great effect, but then that effect diminished a bit. And he was complaining of some tightness in the shoulder still and limited or some slightly limited range of motion. And I was like, well, what if I just looked at some joint mobilizations? And I did some joint mobilizations to stretch out the back of his shoulder where he was feeling most of his symptoms. And immediately after those, he was like, wow, that's way better. I'm so much looser. A lot of that pain and stickiness I had is gone. And I'm like, okay, I guess we should do less needling or less massage and some more joint mobilizations. But today, for example, I did all three of those. And
Whoa.
he was definitely sore after, and he's going to be sore, but he knows that. He just knows that the next couple of days he's going to feel amazing. So
Yeah.
just tweaking the things that you do to better suit the patient in that moment. Sometimes you need to do more manual therapy, sometimes less. So for example, I have a client with tennis elbow right now. I tried to treat it pretty chill by having her do her simple home exercises and have her come into the clinic once every few weeks or something just to tweak those. We did that for like 6 weeks in total. And she saw her sports medicine doctor for a follow-up on the elbow. And they were like, well, what if you just did PT more in the clinic? And she was like, that sounds great. Let's just do that. And so we had a conversation and she's like, I really like manual therapy. Let's just do more of that. And I'll keep doing the exercises at home. And I was like, great. So now I'm seeing her once or twice a week and she's getting a lot better. Maybe it was just the exercises needed more time, but she feels like adding in the needling and some more tissue work in addition to those exercises on a regular basis has been a big boon for her recovery. And I'm not here to say no. If that's something that she would like to do, it's clearly helpful and meaningful to her, and it's totally fine. So of course I'm going to do more of that with her. But yeah, sometimes you got to change the techniques you do as well. Like I said, go from needling to more massage, or go to some more joint work, or God forbid, do some scraping, because why not? And then the last thing I'll say about manual therapy is sometimes you just got to broaden your scope. Maybe you are too focused on the site of their pain. But if you went a bit more above or below, you might find something else that kind of hurts and you work on that and they feel a lot better. So for example, a common one is going to be someone has butt pain or low back pain and you work on either of those because they're so close together and they really influence each other and they can refer back and forth to each other. Working on the buttock can really help that patient's low back pain and vice versa. And so it's okay to broaden to neighboring regions. I'm not going to say I'm going to treat your foot pain by working on your neck, but you get what I mean.
Yeah, no, I mean, I hear you. Yeah, that's 100%. Those are great things to do in terms of just switching things up and changing some different things. And it might sound, honestly, after you're listening to this, and it's like, man, it sounds like you're just throwing stuff at the wall and trying to see what sticks. And it's not like we're just blindly doing that, right? There is method to the madness. But for the respects of this podcast, we're just kind of giving a 10,000 foot view on how we can, do things differently or try and tweak stuff in plans of care to get people better. The next one can be pretty quick because we already talked about this quite a bit, and that's just reevaluating, right? Going, all right, is this really plantar fasciitis, or are we dealing with something kind of weird that we just need to take a look at differently, right? Is this really, something going on with your deep neck flexors of your neck, or is it something else going on that we just kind of missed and that we thought was originally there, but maybe it isn't, right? And so reevaluating the patient and just kind of where they're at. And, one of the things that I like to ask is, what do you feel as the patient? What has helped you out so far? What do you feel hasn't helped you out so far? And it's like, oh, I felt like when we were working out this part of my body, it was actually giving me some relief for us feeling stronger and it's helped me out. Sometimes it doesn't have to be super scientific. Sometimes the patients are they'll tell you, they'll let you know what they need and you can just go with it.
Yeah, 100%. I am a huge fan of reevaluating. Honestly, every session, I go through some motions, just take a step back and then get back into it. And sometimes you just take many steps back, reset everything, do all the tests and more, and then decide, okay, is this what I'm thinking? Is this what I'm not? Just because these problems are like, I don't want to say they're complex in that like it's an impossible problem to solve. It takes a ton of brain power. It's just, there are so many factors that can contribute to these symptoms and so many different ways to get folks better, that you really have to be on your toes the whole time. You can't just be chilling, just coasting, because next thing you know, those 12 weeks go by and you've wasted hundreds and thousands of their dollars, and you just missed this stupid thing because um, the blinders are on, or you're arrogant,
Mm-hmm.
or you're ignorant.
Yep. Absolutely. So then, kind of getting towards the end here, I'm sure Christian and I could honestly go on for a long time about different things that we could change, but we are trying to keep these podcasts short-ish and succinct. So in our hopes to do that, the second to last one is referral. We already touched on this. I went on my soapbox and I gave my little speech about it, but worth time and money, right? Do we need to get you to maybe a different PT? Should we look at different providers? God forbid we have you go to a chiropractor. Jesus Christ, as a physical therapist, who would guess? Maybe you need to go to a chiropractor. They're going to help you more than I am because they have a different skill set. They have a different way of looking at your body. Maybe that's what you need, right? Maybe referring out back to the referring provider, to their primary care to get some different workup done. Funny story, I just saw a primary care doc at the hospital. We had a good conversation. And at the end of the conversation, I go, yeah, doc, hopefully I'll try not to bug you too much and ask you for different referrals for the patients. And, because doctors love it when we spam them in their inbox because they have a million messages to go through and we ask them for different referrals. And he kind of laughed. He's like, don't worry about that. Let me know what your patients need. It's reaching out, getting the patient something else. As much as we love PT, as much as we think that this is one of the better ways to get people better, it's not always the golden ticket every time. And so referrals and maybe switching up how they're being treated with a different provider can really be what they need.
Yeah, totally agree. Nothing to add to that. I think you made a good point there.
All right, awesome. Okay. And then lastly, this is maybe going to sound like a weird one. This was one of my things that I wrote down, but sometimes just taking a break from like everything, right? Patient stressed out. They're working 7 days a week. They got 3 kids at home. They're having trouble making ends meet. They want to rip their hair out. The last thing that they want to do is make another 4 visits with PT because they don't know how they're going to fit that in or how they're going to pay for it. And sometimes just saying, hey, here's what we know helps you at home. It might not get you all the way there. Let's just take a little break from coming in. Just ease up your schedule a little bit, make things a little bit more comfortable for you. Sometimes taking a break can be what the patient needs and really help free up, like I said, time, money, etc.
I just had a patient last week come in. She might have been 2 months, once or twice a week with our pelvic health team doing pelvic health rehab, but also has a hip thing. And she was referred to me once the pelvic health stuff was done. And she was supposed to come right away and she was on my schedule, but then she canceled last minute. And then she just disappeared for 2 months. And then all of a sudden she was back on my schedule. And one of the first things she said was, she was like, oh, I'm sorry, I canceled. And I know I was supposed to be here, but I just needed to take a break. I felt like that I'd been doing a ton of PT for a while. I just wanted to just stop, reset, not have so many appointments on my schedule each week, and just come back when I felt like I was ready. And she's like, I'm here now. And I was like, cool. Do you feel better? She was like, yeah, I felt like it was helpful. I'm like, great, we're good. Let's start now.
Mm-hmm.
Sometimes it's just what you need.
Mm-hmm.
I do not want you to feel like coming here is a chore. It already is a chore. Let's be real. Coming to see us, you don't want to be here typically. It's expensive. It takes time, etc. But don't make it feel even worse. I don't want that to be how you feel. And if we just need to take a break, I'll make sure you got a pretty robust home exercise plan or whatever advice we got to do. You go do that. You call me if or when you need me, or like, let's plan to see you in a month. If that appointment comes by and you're getting really close and you feel great and you want to cancel it, cool. Just cancel it. Tell me why. Tell me you're feeling better. Or if you just cancel it altogether because you just can't do it right now, that's fine too. Like, it's your life. You do what you got to do. I'm just here to support you.
Yeah. I think didn't Bon Jovi write a song about that?
Oh God, I hope not.
No, what's
Quote Bon Jovi right now?
Wait, is Bon Jovi in the news for something? Am I missing out?
Well, I don't know. No.
Oh, okay. I thought Bon Jovi got like hit with some lawsuit that we shouldn't be
Oh, I'm
endorsing.
sure he's got some in there somewhere. Come on.
But no, isn't there a song? Maybe it's not him. God, I'm bad at this. Of like, I'm not even gonna try and sing it, but they talk about like "It's My Life," and like they're giving
Yeah,
you
yeah. Yes, of
Is
course.
that
Everyone knows that song.
Bon Jovi?
That is Bon Jovi. Yeah.
Nailed it.
I think
I'm
you nailed it,
terrible.
but okay.
I'm terrible. I'm terrible at music. All right. Okay. Well, there it is. There is our very condensed version that Christian and I can do about what, why, and how we help people when they're not doing better, and kind of having that ability to say, yeah, not everyone does get better, unfortunately, and we try our best with that. And we work with the patients, and at the end of the day, it's not the patient's fault. It's not our fault either. We're trying our best, but the human body can be one tough son of a gun. And so, we do what we can, and most of the time, I would say it works out. But some of the times, unfortunately, it doesn't. And kind of things that Christian and I laid out tonight is what we try and do when it doesn't work.
I think one big reason we didn't say that we should is that your PT might be bad. Like you could have a PT that just doesn't know enough. Like I've been
Okay.
that. I feel like I definitely have been. I've been really bad. But I'm sure there's still times every week where I make bad decisions. But like that is also one that can happen. And then if you feel like your PT is just not competent enough, please go to a new PT. It's okay. They'll get better eventually.
Yeah. The PT curriculum is getting soft out there. Christian would know. You teach at a program. You're being light on kids nowadays, just letting anyone through. I'm just kidding. Christian does a killer job with that. But anyways, yeah, that's a fair point. Yeah, I was trying to be the nice one here and not throw other people under the bus. But bring up a good point there.
Gotta be honest.
That New England vibe is really rubbing off on you, huh?
I love it. Just tell it like it is, Eric.
Yeah, fair. Yeah. Anyways, well, if you're listening to this and you have something that isn't getting better and you want new ideas, hit us up. Let us know. Christian, I would love to chat, try and figure out something that can work for you. But in the meantime, we're gonna keep piling through and get out some more content for everyone to enjoy. And hope you all enjoyed it. So thanks so much for the chat tonight, Christian. We'll talk to you later.
Later, dude.
See y'all.